Today we have Dr. Tina Zhou, one of our C2 KGY5 cardiology residents, to talk to us about an interesting topic. When an echocardiographer and a physicist walk into a bar, not an ideal situation. Take it away, Tina.
Thanks, Mike. I try hard with the title. I apologize, it's not the greatest. But the impetus behind this talk was I just did 2 months on echo and doing the process of learning to read, went through a lot of the underlying principles being used in echocardiography and realized there were a lot of assumptions. And as I'm making this presentation, it felt like I was back in high school days when you're in physics class. And this is what happens when you assume X, Y, Z. And we know in real life, these are not always true. So my goal today is first to review the principle of continuity and conservation energy and demonstrate how these fundamental physics principles are used in echocardiography. We'll illustrate with some cases when assumptions used in these principles are violated and how measurement can be affected. And we'll have some selective comparisons between echocardiographic and invasive hemodynamics. So first of all, starting with Bernoulli's principle, who is Daniel Bernoulli? He was born in 1700 and died in 1782. For someone who was born before the age of antibiotics, that's pretty impressive. He lived about 82 years old.
That's seriously good.
Yeah, I know. Nowadays it's pretty good. He was born into a family of mathematicians, so his dad was also a very famous mathematician, so was his brother. One can only imagine what a Thanksgiving dinner is like. He studied philosophy, logic, and medicine, got his MD degree, published Hydrodynamica, which is sort of where Bernoulli's principle came from, one of his probably best known publication. And he received a lot of prizes for various works that he did, including astrology, gravity, magnetism, ocean currents. And they didn't put on a page, but he actually had an appointment for botany. So he had plant science and human science. I don't know how that worked back then, but makes you wonder what I'm doing at age 30-something. Now, going actually into the principle itself, what is Bernoulli's principle? The idea is that the pressure in the fluid decreases as the velocity increases. And it comes from the idea that energy is never lost, only converted. So in the context of fluid dynamics, it's the idea of potential energy being converted to kinetic energy. Graphically, this is what it looks like. So on the left-hand side, as the fluid travels, and here you have lower velocity fluid with higher potential energy as it goes through a tight space. The velocity increases, the pressure decreases, and as it enters a larger space, the velocity decreases, the pressure goes back up. And the idea is that the energy is conserved throughout this closed space in an ideal situation. So a few assumptions. First of all, I assume that there's no viscous loss as the fluid travels through. There's no transformation of the potential energy because of viscous energy, or no thermal loss. I assume laminar flow, that the layers of fluid going through, you can imagine like the air going over a plane. It's layered, smooth, and no turbulent flow. And it's incompressible flow. So the density of the fluid remains the same throughout each point in this closed system. And then lastly, steady flow, that the velocity and pressure cannot change at any point. So I think this is more referring to the time point, not physical point. So what does the equation actually involve? So I will walk everyone through it. So the capsized piece is pressure. So pressure in the system plus sort of the potential energy. So this here is the fluid density, the height, and the height and gravity constant. Plus this is the fluid density plus velocity. So this is the kinetic energy of the fluid. So at any point, the summation of these types of energy equal the same. But in echocardiography, we assume there's no height difference because patients' heart more or less stay at the same level. So we can ignore the term that includes height and gravity, and it converts into potential energy plus the kinetic energy. And when you rearrange that, that gives you the pressure gradient, and that is the difference between the kinetic energy. And when we rearrange that, this is ultimately the equation we came down to, which is half of the density multiplied by the difference between the square of the two velocity at two different spatial points. Now, the fluid of interest for us is blood, and this equation, with the density of blood considered, becomes 4 times the difference between the v squares. Now, why is it 4? That's the question that I was asking myself when I was going through this. So, while a bit of a deep dive, this is just for interest's sake. We're not going to change the constant. Where did the 4 actually come from? As you remember, on the left-hand side, this pressure difference, which is millimeter mercury, and on the right-hand side, this density multiplied by meter square over second square. So, because some part of it comes from the unit conversion, so to speak. So 1 millimeter mercury increase 133 Pascal, which is 133 kilogram over meters second square. And the density of blood is 1060. So when you plug that in, it works out to 3.98, which would be approximate to 4. So that's where the 4 came from. Now, some interesting historical studies I discover in this case is that the density of blood is not always constant. So here is a study where they looked at 6 healthy individuals, and I don't know how they measure this, but they measure the blood density for these individuals between sitting, standing, and supine. As you can tell, there's actually quite a decent change. So, for example, here you're looking at 1045 and then 1051. Here 1051, 1057. So it's a little bit changed, and it's higher when a person is standing when he's sitting. And for us, because we scan supine, so I guess the density is actually the lowest of the 3 positions. Not that this will change our practice, I just thought this was interesting that we used to publish things on this. And the other piece is the hematocrit. So the blood viscosity, also the blood density changes as the hematocrit changes. For the most part, I don't think it significantly affect our echo measurements, but there's something to keep in mind. Now, shifting gear a bit, talking about the continuity equation, it's ultimately the same idea of conservation. Instead of here, energy is conservation of mass, and graphically, this is what it looks like, that the flow rate at any point in the system remains the same. And the flow rate is the product between the area and the velocity through the area. So that works out to be A1 times V1 equals A2 times V2. And for us, we're usually interested in one of the 2 areas. So when we rearrange the equation, we get the A1 times V1 over V2. Now, in terms of application of these equations, so starting with the aortic valve assessment, probably what we're most familiar with. So here the closed system is the LVOT tract, the aortic valve, as well as the aortic root and ascending aorta. So here we have the velocity through the LVOT that goes through the stenotic valve and then have flow outwards. And usually we're interested in this pressure gradient as well as this valve area at V2. To measure the mean gradient across the valve, we use our Bernoulli equation, and which is the 4 times the difference between the v squares. But we usually assume the v1 is less than 1 or rather negligible in the LVOT area. So when we get rid of v1, it becomes 4 v2 squared. To measure the aortic valve area, so that's when we use the continuity equation. So CSA stands for cross-sectional area. So we look at the cross-sectional area in the LVOT measured by the VTI equals the aortic valve area here, multiply the VTI at the aortic valve level. And that worked out to be pi times the half of the diameter we usually measure squared. These are familiar equations to everyone in this room. So when does a simple Bernoulli equation fail? So first of all, this is more of a measurement error rather than true assumption error, which is if we don't have our jet our Doppler aligned to the direction of the flow, then you can underestimate the gradient. But I know as a team here, I try really hard to always make sure that we interrogate appropriately and use different views. So this is not really a huge issue, but more so than that, in other scenarios, for example, if you have subaortic stenosis, with especially muscular subaortic stenosis, it actually changes the shape of that LVOT into the aortic valve. And these are when some of these assumptions need to be taken into consideration. So for example, the viscous friction in this case is not negligible because it's now going through a longer area of stenosis. So you end up with more viscous loss, so it can underestimate the gradient. The other piece is when your pre-stenotic flow velocity is not negligible. So when your V1 is greater than 1, it can lead to overestimation of gradient because it's not taking into account that V1 square, which we will demonstrate. And the last piece is the idea of pressure recovery, which I'll delve more into in the slides after this. So I guess first question is, what is the problem with this gradient measurement? So on the left-hand side, you have your LVOT, and the right-hand side, you have your aortic valve, and here the mean gradient is about 15 to 16. Anyone?
IV1.
Yes, we set that. I think we were. Thanks, Bodhi. So on the left-hand side, you can see that the max velocity is 1.5, which is actually not the best example. I was just going through the echoes I've read in the past few months. This is sort of the best I could find. But this would violate that simple Bernoulli's equation assumption. So as a result, the gradient is not as reliable here. And when this happens, we use to modify Bernoulli's equation, which is on MD Math's website that Dr. Zhou designed. And so instead of doing 4V2 squared, we actually have to plug in the V1. Now, a note on that is it can correct for peak gradient, but not quite the mean gradient, or rather, it doesn't give you a number for the mean gradient. And the reason for that is when you look at this picture, I'm not sure if you can quite tell, this is sort of the LVOT VTI, and this is the aortic valve VTI. So what this equation corrects for is actually just at the maximum velocity. So this V1 squared minus this V2 squared. Truly, if you want to correct for VTI for the mean gradient, then you have to actually sort of subtract this entire area, subtract this area from this area to obtain the true mean gradient. And we don't really have a simple mathematical way of doing so, but it should prompt us that our gradient is overestimated, our mean gradient is. Now, the second piece is, as I mentioned, the continuity equation depends on the LVOT area measurement. So this, with the show of hand, assuming VTI measurements are the same, a change of LVOT diameter from 1.8 centimeter to 2 centimeter will change the valve area by A, 5%, B, 10%, C, 15%, D, 25%, approximately. How many say A? B? C? So is everyone saying D? Yeah, fair enough. Yeah, it's pretty close. So if you if you overestimate it, this truly is 1.8, but you estimate it to 2, you can overestimate about 23%. Vice versa, if you're under measuring, so if the true LVOT is 2 centimeter, you measure at 1.8, you will underestimate about 19, so almost 20%. It's pretty significant. And yeah, it can make the difference between severe versus moderate aortic stenosis. Now, a little bit about LVOT geometry. So we assume that LVOT is circular, and at where we measure is, but in reality, LVOT is more of an elliptical shape. And what we measure is actually the shorter diameter across here. So here you can see that the LVOT we measured to 16.8, and the minimal axis on CT is 16.9. So this is what we're actually measuring. So our area is, as expected, underestimated. So here is 222 or so, and this is 327. But frankly, of all the sort of area assumption that we make in echo, LVOT probably is the closest to being a circular geometry in someone who otherwise does not have any pathology in the LVOT, assuming you have no dynamic LVOT obstruction or other anatomical challenges in the area. So it's pretty good. It's not perfect, but it's a pretty good assumption. Okay. So further on that, demonstrating how different it can be in terms of how you measure it. So here we have a prospective study that look at standard TTE, so where we measure LVOT on the previous slide, versus using biplane TTE versus doing cardiac CT, which here is used as the gold standard. Without any interest, it was looking at how different they are. So on the top are 134 patients where they only looked at the two different ways of measuring with TTE, and you can see the biplane TTE actually gives you a much bigger number on average, but it's harder to do. And when you compare to the gold standard, even biplane is still less than cardiac CT. So ultimately, like I said, as long as we're internally we were consistently wrong in our assumption and measurements, I think that should be okay, but recognizing this is a challenge in using the LVOT area assumption. And what does that clinically affect? So, this just demonstrates that if you're using aortic valve area less than 1 as sort of the definition of severe aortic stenosis, having different, having more accurate measurements of the LVOT can actually reclassify the level of aortic stenosis. So on the top is patients with high grading aortic stenosis, so your classic mean grading greater than 40, aortic valve less than 1. The classification rate is actually not that high. Only about 7% is reclassified as moderate once they use the biplane LVOT measurement. But when you look at sort of the lower gradient normal flow, aortic stenosis on the bottom, so mean grading less than 40, normal stroke volume, the classification rate can be up to almost 2/3 of quote unquote severe aortic stenosis. Now, I think since this paper has been published, our guideline for aortic stenosis grading has sort of changed, and now the aortic valve area is not the only if used at all in terms of severity of aortic stenosis. So I think the bottom line really is to use all data points to determine severity, because if you look at the mean gradient and the stroke volume on the bottom row, you actually wouldn't have thought that this is severe. It's really by the aortic valve area. And the other piece to hammer home is we need to be consistent in our LVOT measurement throughout serial echoes, so that we can actually compare our numbers across different echoes. So switching gear a little bit, another thing that I noticed when I was reading in the past 2 months is frequently post-TAVI, patient could be freshly out of the cath lab with a less than day old or a day old TAVI, but the gradient is already 10, 12, 14. I remember thinking that's a bit weird. It's a brand new valve. What are we seeing here? So on the left, this is for the same patients. On the left is the invasive hemodynamic measurement in the cath lab, and when I did a pullback, or in this case, simultaneous measurement, the LV pressure is the sort of deeper waves, and then the aortic measurements is sort of the less so. The smaller amplitude one, and the mean gradient is only 2. But when we do echo measurement, the mean gradient is 16. So it's a pretty significant difference. And as I'm learning more about the this topic, it started to make sense more. And it really goes back to another assumption that's being violated in Bernoulli's principle and continuity pressure equation, and this pressure recovery phenomenon, whereby there's discrepancy between Doppler measurements and invasive measurement, like I demonstrated on the last slide. And what pressure recovery is the increase of pressure downstream from stenosis caused by reconversion of kinetic energy back to potential energy. So graphically, what this looks like is that as the blood exits through the LVOT, the pressure decreases, velocity increases, and by the time it gets to the stenotic valve, the pressure, like I mentioned, decreases. And as it continues through the aortic valve, the pressure recovers a bit as the velocity decreases. So it goes back to that principle of energy is never lost, that you have potential energy being converted to kinetic energy, being converted back to potential energy. And that second conversion, so to speak, is the pressure recovery phenomenon. So when I first read this, I was thinking, well, by this logic, the larger the ascending aorta, or where the blood exits from the aortic valve, the better pressure recovery should be, right? Because as you're going into a bigger space, your velocity is lower, and therefore your potential energy should be higher. And this is wrong. Don't actually quote this picture, but this was some Sunday afternoon trying to figure out how this pressure recovery phenomenon works out, and this is how I felt. After much research, what we realized is that what the pressure recovery phenomenon really involves is the violation of some of the assumptions in the Bernoulli's equation. As I mentioned earlier, the assumption is that you have potential energy plus kinetic energy at one point, which equals potential energy plus kinetic energy at another point. But in reality, in aortic stenosis, the fluid passes abruptly from a big cross-section to a small cross-section to another larger one. And as it goes from a small cross-section to a large one, this sudden expansion actually creates a lot of turbulence. And so that it creates viscous energy loss, it creates thermal energy loss. So in general, there's actually a loss of energy as it's passing through that stenotic valve. So this conservation of energy no longer holds, that you have to add another constant. I can't explain to you mathematically what that means, so I'm just going to call it other stuff. But if, hypothetically, the expansion were to occur gradually in a gently tapering section, then much of the kinetic energy available in the jet could be recovered. So as the flow decelerated, that will become, that will take the form of increasing pressure. So you actually have more efficient or higher pressure recovery if the tapering were more gentle. Now, in the world of physics, looking at fluid dynamics, so this is graphically what it looks like. So if you have different types of stenosis, so you have the orifice, the nozzle shaped, and sort of a more Venturi shaped. So the Venturi one will maintain this laminar flow the best, while the other sort of shorter and more abrupt change in flow will create a lot more turbulence, which makes sense. And when they looked at in vitro studies and actually measure the pressure recovery in a nozzle valve, where you have some degree of tapering here, but still fairly abrupt change with some turbulence downstream from it, so you recover about, this is about 35%. Of your pressure. Well, if you have a Venturi tapering, the loss is only about 15%. So you can recover actually up to 85% of the pressure drop. It's pretty remarkable. So now the question, Doppler versus invasive hemodynamics, because the gradients are different. Which one actually matters more? What do people think? Doppler? I'm asking a group of echocardiographers. Doppler or hemodynamics? Should everyone get cast?
If Doppler's not wrong, it shows you what the fastest the blood is moving through that narrow orifice, but what does the patient and the patient's aorta see?
Yeah, that's exactly the question. Is like, what does the patient's heart actually sees? And So I can't really quite explain the physiology, but the thought is that the net pressure gradient, which is measured by invasive hemodynamic, is more clinically relevant because it represents actual hemodynamic burden on the LV. So Dr. Chisholm is not here. I hope he's happy. He was the one who taught us this in the first place. So I am grateful for him, his hemodynamic rounds. Now, how do we actually correct for pressure recovery if it can be so important and significant? So there are equations. I won't go into the details of it, but this is the ultimate equation. So the net pressure gradient, again, this is the max pressure gradient rather than mean pressure gradient, is a difference between what we measure on echo minus this correction factor. What's important here is this term it's actually the ratio between your effective orifice, so at the aortic valve level, versus the ascending aorta. So ultimately, how much the pressure recovers actually just depends on this ratio between your valve and the ascending aorta. So the bigger this ratio, the more different the two areas are. So if you go from a very small to a very big aorta, the more energy loss you have and the less pressure recovery that you will have, and the closer your echo measurement and your invasive measurements will be. And this tends to be the case for people with severe aortic stenosis from degenerative calcified valve. These tends to be elderly with long-standing hypertension. Their ascending is like close to 4 centimeters, if not bigger. So we don't have to worry as much about pressure recovery. But it becomes more relevant when the ascending aorta is actually small. So sometimes we see that with elderly, tiny ladies, although indexed BSA actually may not be that small, or people with congenital valve dysfunction and haven't had the time to actually develop dilate the ascending aorta. So put into practice, how big can the difference actually be? So someone handily created a calculator. So on the left-hand side, if you putting a bunch of numbers. Here I putting peak velocity of 4 and a bunch of BTIs seems reasonable. With a ascending aortic diameter of 3.6, which I think is a fairly reasonable one that we see normally. And the result that you get with an aortic valve is 0.88 centimeters squared, which would fall into or suggest a severe aortic stenosis. But when you correct it for pressure recovery, it's actually closer to 1. And the peak instant gradient measured by echo 64, and you actually recover 10 millimeter mercury from that. So it's probably close to 15-16% of it. But when you're putting a diameter of 2.7, which I recognize a bit extreme, but if you decrease your aortic diameter quite significantly, your aortic valve actually now bumps you up into more moderate range, is now over 1 centimeter square, and you recover 17 millimeter mercury of your pressure, which in this case is close to 25% of your overall pressure. So it can be quite significant. I'm not proposing that we have to do this for every single patient, but this is something to know about. So when should we correct for pressure recovery? There's some suggestion that maybe we should do that for small aortic size, but then again, it really is a patient. There's small patients with less than 3 centimeter aortic size. There's big patients with less than 3 centimeter of aortic size. So I think a cutoff that's not indexed to BSA probably is not as useful. The other scenarios when you have congenital aortic stenosis, but I think it's not necessarily the aortic stenosis itself, it's more so the fact that the ascending aorta in these patients had less time to dilate, and therefore perhaps this phenomena is more relevant. Another interesting one is mechanical valve, specifically the bileaflet St. Jude mechanical valve. There's some literature demonstrating this, that the cath gradient, the echo gradient can be quite different. It has something to do with how the valve is designed, and the way the valve opens makes this flow through the stenotic valve or flow through the valve less turbulent. And the correction factor that was empirically derived can be up to a 40% difference. But again, I don't think this is common practice to correct for it. And the last piece, the aortic root repair, which again has something to do with the fact that the root is now a lot smaller. So even the valve itself hasn't changed in size. You may end up with a different gradient because of it on echocardiogram. So going back to that case, why is the echo gradient so much higher post-TAVI? So this was actually quite interesting. The more I read about it, it's not just the fact that they're different, but they're also different between different types of valves. So this study actually looked at the sapien valve versus core valve and compare the Doppler measurements and invasive measurements. So it's not how I would have presented this data, but I try to compare so that the same color bar next to each other. So for example, for sapien, there is a relatively bigger difference between the Doppler and CAS gradient versus the core valve. And so that this is what that demonstrate on the right. And what they showed is that it has something to do, so this is from a different study, so it's not necessarily comparable, but what I'm trying to demonstrate here is that the different types of valve, because of the way it tapers, creates turbulence differently. So certain types of valve. So certain types of valves will give you better pressure recovery. So for example, this valve on the right versus the one on the left, because the left has more turbulence, so you have less pressure recovery. So the echo gradient and the path gradient are less different. So that is something to keep in mind. The bottom line here is that it's not that we should cath everyone. It's not that we should not trust the echo gradient. It's just important to establish this post-TAVI baseline, so we know that this is what the echo shows, and then we can trend over time. And if we do notice change in gradients, in the case of prosthetic valve, in that scenario, I actually do think it's important to confirm with invasive measurements, just to make sure that pressure recovery is not the reason. Okay. So that was all about aortic valve. There are a few other scenarios and measurements that we use in echocardiography using these principles, and RVSP is one of them. So essentially what we do here is that we measure the tricuspid regurgitation here, and using the velocity estimates the systolic pressure here. So pressure or potential energy transformed into kinetic energy. And what we traditionally use is 4V squared plus the RAP. So the RAP is sort of the existing pressure in the atrial chamber. And we use as a surrogate for pulmonary arterial systolic pressure, assuming a few things. That one, RAP can be accurately measured. RAP on that one, it often is not accurately measured, but we use it. There's no RVOT obstruction, there's no pulmonary stenosis, it's a closed system, no shunts, and no severe TR, because then you don't really get a pressure gradient and definitely cannot rely on your RAP assumptions. So in scenarios where you have a pulmonary stenosis, so what do we do about that? So then we have to add that pressure gradient across the pulmonary valve in addition to the RVSP to estimate a pulmonary arterial systolic pressure. So just involves adding a few more things into it, or mentioning that the RVSP will be an underestimation of PASP in our reporting. And the other piece is, what about VSD? So that violates this closed system, no shunt assumption. I won't go into the details of it, but instead of measuring the velocity through the tricuspid regurgitation, what we really need to measure is actually velocity through the VSD. And in the case of left to right shunt, you subtract that from the systolic pressure. In the scenario right to left shunt, you add it to the systolic pressure. The idea is that if there's a shunt, the two ventricles, the pressure will equalize by the end, therefore correcting it with the systolic blood pressure. Now, assuming that we actually do measure correctly, what can still go wrong with RVSP measurements? So there's actually quite a few studies comparing echo versus invasive right for CAS. In this case, is in pulmonary hypertension. There's some moderate correlation between Doppler echocardiography and right heart cath, but there's pretty wide range of overestimation and underestimation. And assuming that we're estimating correctly, why is it so different? So there, going back to the Bernoulli assumption, there are actually in vitro experiments on this that I found interesting, which this seems to be a theme while I was studying for this. People would actually create these chamber fill it with glycerin of different percentages to mimic different density, have a transducer sitting one end, and actually have controlled flow, simulating flow through the valve on the other end. So this is a setup here, and imagine this is a tricuspid valve. And so they changed the density of fluids, but they also added some various chamber interactions, so to speak. This is to simulate sort of more eccentric jet hitting a chamber. And they also had different sizes of chamber, but I'll just show you some selective result that they found. So for example, if you have a very eccentric jet, that would interact with a nearby atrial atrial wall. So that actually creates some viscous energy loss that, again, was not present in Bernoulli's equation. And they demonstrated that there's a noticeable difference in terms of the error, so to speak, between the echo measurement and the actual flow rate. And the increased blood velocity also makes a difference. And it matters in pulmonary hypertension, where some patients they may be more hypoxemic, especially people with shunts and isometric physiology, and the hemolytic is different. So this constant of 4 gets violated. And that's just out of interest. Again, I don't know how that works. Change our practice. A few other examples where continuity equation is used. One is mitral regurgitation. So the regurgitant volume is now the difference between what goes through the mitral valve and what comes out of the aortic valve. They should be the same in the closed system, but if there's regurgitation, your flow through the mitral valve will be higher. So plugging that in and how to do it in practice. So you would measure your stroke volume at the LVOT level, and you measure your inflow. Now, of note, the Doppler signal is actually placed at the level of the mitral annular diameter rather than at the tip of the mitral leaflet. And what we're measuring is the area at the mitral annular diameter. I don't think we ever do this, but theoretically you could. And it's assuming that you have no aortic regurgitation, you have no stress. There's a lot of assumption, as Dr. Lempoy pointed out, but it's one way of measuring it, and it applies to other regurgitant lesion as well. So aortic regurgitation, in which case you can look at the difference between the LVOT flow and mitral valve flow. In this case, it will be the reverse, so you have more flow through the LVOT than the mitral valve. And if the mitral valve is not working, you can try the RVOT, which again we actually almost never do, but theoretically you could. Like ideally, like I said, not often ideal. And also to measure mitral stenosis, is the same idea that the flow through the mitral valve is the same as the aortic valve. I like this little graphic representation of how you actually do it. Again, it's not helpful if the LVOT diameter is miscalculated. It's not applicable for patients in AFib. The flow varies beat to beat. And if you have concomitant regurgitation, it doesn't work. So reviewing the echoes I read and came across this report. I remember when I was reporting, I thought it was interesting that the mitral valve area by 3 different methods are so drastically different. So manometry is over 1, and pressure half time is 0.78, and BTI is 0.52.
That's not very important.
Yeah, it's not your report. I don't know if you've signed off on it, though.
That is definitely not.
Okay, anyway, so there are actually a lot of things in this report that could explain why the difference is so huge now that I've learned about this. I didn't go into pressure half time and how we measure and the assumption, but just highlight a few things. So first of all, the patient's atrial fibrillation. Oh, sorry, that in itself would make BTI not accurate. Thank you guys. The severely dilated atrium is actually really more for pressure half time measurement. But let's say if you have mitral regurgitation, if you have chamber interactions, that could violate the Bernoulli rule. The mild regurgitation itself, so that will make a continuity equation kind of moot point. Usually it's more than mild mitral regurgitation that becomes significant. And the last piece is the shunt. Now, I don't think the shunt actually affects continuity equation if you're measuring at mitral valve and aortic valve, but it can definitely affect the pressure half time. So bottom line is that there are a lot of assumptions when we use these kind of equations to measure, and just being conscious of what are the assumptions being violated, and when we see this discrepant valve area or regurgitative volume, etc., look at the report and look at the patient and see why that might be the case. The last piece is the PISA measurement, which everyone here is familiar with. It's also actually a principal continuity. So there is a phenomenon that when liquid flows through a very small circular orifice, it will converge and accelerate just proximal to the orifice, and that form these isovelocity layers in the shape of a hemisphere. And what we can do is, this is more the technical aspect of it, but basically change the isovelocity so we know at this area, at this layer, what the velocity is, and we assume the velocity is the same across, and we can calculate the hemispheric area and calculate the flow from there. Now, one thing of note is the PISA radius actually changes throughout systole, and it changes differently depending on the etiology of the MR. And I think that's important because it actually does affect our measurements. So, for example, in mitral valve prolapse or primary MR, the most common type, we see that it starts in mid-systole and max out during the second half of systole. In secondary MR, PISA actually decrease in the systole, which sometimes can underestimate the MR severity if we're not catching it there. And degenerative and rheumatic MR, it's fairly constant. I can't really find a very good picture, I'm sorry, but I think what we're trying to show here is, so this on the bottom starts into the mid-systole, as you can see, and then peaks out in the second half. So this is your classic MVP. Well, here it's not a very great picture, but systole starts around here, and you can see the MR jet starts here as well. But it peaks earlier. So this is more classic of your secondary MR. Now, some pros and cons. It's not affected by other valve regurgitation compared to continuity. What flows through that valve is what flows through that valve, regardless of back and forth flow rate at other places. So if you have concurrent stenotic lesions like rheumatic hydrostenosis plus mitral regurgitation, it works really well. But it cannot measure more than one regurgitant jets, and errors are often squared. And as you guys are all familiar doing PISA, depending on where you time it, your PISA radius can vary anywhere between, say, like 7 millimeter to like 10 millimeter. So the errors can really get quite large, and is not accurate in non-hemispheric flow, which is quite frequent. So here's another study that looked at PISA regurgitant flow versus CMR, and on the left-hand side, they showed that correlation is not the greatest, and then on the right, again, showed that the errors is quite scattered around 0, which just means that it does tend to under and overestimate. Why is that though? So another in vitro study where they simulated different types of PISA flow with different types of orifice, shape, size, flow rate, etc. And they compared the 2D PISA measurement, which we normally do, but they also do 3D PISA measurement, both in terms of peak PISA, so the largest PISA they could get, versus integrated PISA, where they integrate the PISA size throughout systole and then obtain sort of like a mean recursion volume. What I'm really trying to show here is what's on the bottom. So these different shapes represent a different shape on the left-hand side that they tested through. And when you use a 2D PISA, the volume can be quite different based on what type of orifice shape that you're going through. While using 3D, it's more consistent. So just out of interest, I know we don't really do 3D PISA that much, but theoretically we could. So in conclusion, the conservation of energy and mass is a sort of fundamental principle in echocardiography, and I hope I convinced you that it is present in almost all of the measurements, regurgitation, volume, area calculation, gradient calculation, flow calculation, but there are a lot of assumptions in its application. It's not to say that we should use them, we absolutely should, but it's just important to know how much to trust the results, knowing what assumptions are being violated in the echo that you're reading. Sometimes not ideal is really the best we can get, as long as we recognize what we are assuming and comparing apple to apple between echoes. I think ultimately it's still very, very useful.